I'd like to shift gears a little bit now that we've kind of explored the ramifications of the clinical disease and how people get diagnosed and some of the barriers therein with the overall burden of disease to the healthcare system. And as the person here with the most background on the payer side, I would say that from a payer point of view, when we think about the economic burden of chronic fibrosing ILD with progressive phenotype, it's not something that had been on our radar screen for a very long time. I think this gets to your point earlier, Dr. Danoff, in terms of it being reasonably rare and not something that we were spending a lot of time concentrating on. The new therapies and the pipeline have kind of shifted payers to at least have it on their radar screen, but it's very difficult as payers, and this goes back to the discussion I was teeing up before, for us to just see exactly what the costs are, because we're not necessarily seeing the patients with an easy to search ICD-9 or 10 code or the ability to go in. And so it's reasonably easy to find patients who have been started on a therapy that's specific. Other than that, where we see the costs mostly are the direct costs of healthcare resource utilization, CAT scans, which are mildly expensive, PFTs, which aren't, lots of ER and clinic visits. And what we really see is the barrier to the discussion we were having earlier is the long journey before patients get diagnosed and get onto therapy. So I would say that the economic burden that we are concerned about often is either the amount of time we're spending with patients who are on inhalers that aren't working for them, bouncing around the system from clinician to clinician, multiple ER visits for shortness of breath or related symptoms before somebody nails down the diagnosis and starts therapy. And the other thing that we are starting to pay attention to a little bit now that the disease is the progressive phenotype is coming to our attention is looking for those comorbidities and trying to understand. Some of you have made the observation before that a lot of these patients have multifactorial disease with a lot of different components to it, pulmonologic, rheumatologic, autoimmune, et cetera, and trying to pare back the layers of those comorbidities and even see if there are ways that we can steer patients to earlier diagnoses. But I am unaware of any payer that's been able to do so effectively through analysis of claims data, mostly I think due to the barriers of trying to again, to the point of the relatively rare nature of it, trying to sift through rather all of the chest CTs to try to find patterns to identify patients when we're dealing purely with coding data and billing data. The economic burden as the disease progresses to us tends to be more around chronic care. And in some ways, it's simplified by when the patient actually gets a diagnosis. And now we know what's going on with the patient and they're in a care plan and a treatment plan, as you guys have been discussing it and sharing with us. And so the economic burden then also goes back to the employer, where they're looking to see whether or not our therapies and our ability to do disease management or to work with the clinicians around this and to tailor therapies to the right patient population, balance the cost that they're bearing in terms of their cost of the premiums that they're covering, and balancing that off with patient care, good outcomes, and presenteeism and people being able to be more active in the workplace.